Okay, good morning, everyone. Welcome once again to the breakfast at the UMHealth CME program. So my name is Dr. Imran Idris. I'm very delighted to be your moderator for today's CME. And we've got quite a packed session today. We've got 4 speakers. So I'd like to start by introducing what we'll be doing today. So if I can just show you this to begin with. Okay, so to give you some background of what we'll be doing today. So the Faculty of Medicine Best Publication Award was initially set up around 2006. This was when the Academy of Sciences of Malaysia decided to confer the Mahathir Science Award to the Faculty of Medicine, University of Malaya, for the exemplary way the team handled the Nipah outbreak and for their outstanding scientific work, which has greatly enhanced the image of the nation. So the award was subsequently used to promote neuroscience research at the Faculty of Medicine, and the award was named the Faculty of Medicine Best Publication Award. And to reiterate, the Nipah virus team was led by Professor Emeritus Dato Dr. Tan Chong Tin, and it was a multidisciplinary team that did very good work. So the selection criteria for the papers, basically there were 3. So we looked at the overall quality and significance of research. We looked at the degree of relevance to the field, as well as the impact factor of the journal. And this year, we had a few judges from internally and as well as externally. So the clinical side of things, we had Dr. Tai Xin Yu from the University of Oxford in United Kingdom. And for the basic neuroscience papers, we invited Associate Professor Muhammad Farooq Sheikh from Charles Sturt University in Australia, as well as Dr. Amir Arif Hassan from UNSW Sydney, Australia. So I'm very delighted to announce the winner of the clinical best publication paper. This paper was published in Vaccine, and it was entitled Vaccine Candidates Generated by Codon and Codon Pair Deoptimization of Enterovirus A71 Protect Against Lethal Challenge in Mice. And in a minute or two, we'll be hearing from Professor Dr. Chan Yok Fan about this piece of exciting research. And I'd also like to congratulate Dr. Lai Siu Tim, who published a randomized control trial on the mindfulness-based intervention to promote psychological well-being in people with epilepsy. So without further ado, I'd like to invite Professor Dr. Chan Yok Fan to share with us her exciting research. The floor is all yours.
Thank you, Dr. Imran. Can you see my slide?
Yes, we can.
Yeah. Okay. Is it on presentation mode? Yeah. Okay. I'll just start now. Thank you, Dr. Imran, and thank you for the award. And I'm proud to announce my team members. So this is a student, Michelle Lee, who has done most of the work. This is Dr. Tan Chi War, who is now in Duke and US as an assistant professor. Dr. Anthony T, who is currently a postdoc in University of Geneva, and of course, my great collaborator, Associate Prof. Dr. Ong from Biomed Science, who have done a lot of animal work with us as well. And the project is funded by eScience Mostly, and of course, we are very much grateful to Animal Experimental Unit, not just UM, but we did a lot of work in UKM as well. So I'd like to briefly explain steps for vaccine development, as this paper is mainly on vaccine development. So you get a candidate and you need to refine it, and subsequently you will need to do preclinical and clinical, and that's of course take 10 to 15 years at least. From the candidate, what you need to know about the disease is definitely the epidemiology, disease burden, clinical correlation, and which antigen is immunogenic. So over here in this particular short paper, we will explain the vaccine design, in vitro studies, and small animal studies. And with that, to show you how it can be protective immunity and correlates with protection. So of course, this vaccine has the potential to actually go subsequently to clinical trial as well. So a bit about EV71. So this is it's a very small virus, about 7.4 kb, from Picona viridae, which is also where poliovirus is, where the vaccine is available. So we strongly believe enterovirus, you can also, EV71, you can also make a vaccine. So it's what is important here is the capsid. So capsid is where the virus bind to the cells, and we know that it's important for antigenicity, and the rest are non-structured proteins which are important for replication. So what's very, very much known about enterovirus is there are many receptors, and that's being used to bind to the cells. So it can cause various diseases, mainly hand, foot, and mouth disease. You can see vesicles in the hand, ulcers in the mouth, and so on. However, there are also severe neurological complications reported, such as septic meningitis and brainstem encephalitis, mainly in children, young children and infants less than 5 years old. So fatality has very much associated with EV71, and there's always a long-term deficit neurological sequelae, such as attention deficit and so on. So we know frequent epidemics occurs every 2 to 3 years in Malaysia as well as in other parts of Asia. At the moment, no antivirus are available. Vaccines is only available in China. So a bit about our design. So we are interested to make a live attenuated vaccine, but in order to make a live attenuated, there must be some different concepts. So we use a concept called codon bias from what we know about nature, the human evolution. So codon bias is actually how preference of specific codons is being used to encode for amino acids. So for example, this adenine is coded by 4 different nucleotides, and you can see GCC is highly preferred and GCG is least preferred, and therefore we use GCG as the codon de-optimization. How about codon pair bias, which we also use in this paper? Basically, we know that alanine and glutamic acid at this particular codon, GCA-GAG is highly preferred, but GCA-GAG is less preferred. So therefore, we actually will use codon pair optimized using GCA and GAA. So with this, we actually have constructed 12 different viruses, 12 codon de-optimized, 6 codon de-optimized, and 6 codon pair de-optimized by changing these 3 different regions, X, Y, Z. So what we did, of course, I told you we did some in vitro studies. We need to characterize the vaccine candidate. So we did cell culture, we did plug assay to know the infectivity, and we grow them in 39, and we found that they didn't grow as well. As you can see, less plug in some of this construct compared to the wild type. So therefore, we concluded that this vaccine candidate is attenuated. Next, we put into the mice, and so basically we put into adult mice, and we actually bleed them. And when we take the blood, we found that, they have good IgG as compared to the wild type, which is red color, and Mohd, of course, has no IgG. And when you do a neutralization, you expect that all the candidates that we actually did only 4 candidates, X and XY, and we found that only X gave us very good neutralization antibody, but lacking in XY that we have actually constructed. So next, if you see this one, we wanted to know if that's antibody being passed to the offspring. So we mated this particular immunogenized mice and then test the offspring. So when we test the offspring, we challenge it with the virus, and what we found is, as you can see here, the survival is 0 in Mohd, and in the survival for X and also X 100%, and for the wild type also 100%. However, unfortunately, the XY construct did not give full protection. So we went on to also look at active immunization, meaning that from the young mice, we directly inoculate live attenuated virus. And here we can actually see now 3 constructs were actually completely protected. And however, our CPD-XY, they are only 40% protected, as you can see here. So actually, some mice died as well from this construct. So with this, our paper summarized that we can easily use this proof of concept codon de-optimized and codon pair de-optimized for live attenuated vaccine. And this is quite a new concept rather than just having a virus and passage them over time. And we found that immune protection in EV-Xenon definitely requires both humoral and cellular responses. And we now have 2 candidates, codon de-optimized X and codon pair de-optimized X, which actually have good neutralization antibody response, confer protection, and are promising live attenuated vaccine candidates. So we have actually filed a patent for our EV-Xenon, and we know that actually this concept is actually also used in other viruses such as SARS-CoV-2, RSV, dengue, and influenza. So the good thing about this work is it also helped us to get another good thing. We actually use some of this construct and collaborated with US and got a Nature Microbiology paper in 2022. So with that, I thank everyone for your attention. Thank you. Over back to you, Dr. Imran.
Thank you very much, Prof. Chan, and congratulations on the excellent work. I'm sure you will continue doing excellent work in the future. So I'd like to move on to our next winner of the clinical paper this time, which is Dr. Lai Siu Tim. And we will be hearing about a randomized control trial on how mindfulness-based intervention can be used to promote psychological well-being in people with epilepsy. So over to you, Dr. Lai Siu Tim.
All right. So, well, thank you, Dr. Imran, for the introduction and as well as fellow panelists for this award. So this is my disclosure. So for the upcoming 15 minutes, this is what I'll be covering in terms of providing you the brief overview about epilepsy and why research has been focusing on well-being, looking into the study gaps that flows into my current research objective, and we'll navigate through the design of this intervention, how it was delivered to the participants, and providing you the key findings of the results, followed by the discussion where we highlight the concluding summary, the strengths and limitation, and not forgetting future directions in terms of leveraging the learning in the realm of epilepsy. So we have known that epilepsy is a chronic neurological condition that affects around 50 million people worldwide. And it is so common that it actually shows that about 80% of people with epilepsy live in low and middle income countries. Now, it is estimated up to 75% of them could live seizure-free if they were properly diagnosed and treated. Of course, the treatment gap varies in different geographical regions and across different countries. This actually puts them at a greater risk of premature death compared to normal healthy adults. In addition to that, people with epilepsy and their family face stigma and discrimination. And it is very common that people with epilepsy are at a higher risk of developing psychiatric comorbidity. And this was highlighted in a recent forum that was carried out last month pertaining to the psychiatric comorbidities in people with epilepsy. So what makes this a very special focus in the forum? Why do we look into this relationship? It's because in the last 10 years in this field, the relationship between epilepsy and psychiatric disorder is not unidirectional, as we can see in this nationwide registered base cohort. We can conclude that epilepsy can be bidirectional with the psychiatric condition, and that in terms of this research, it shows that the psychiatric disorder can precede the onset of epilepsy. So what can we do about it? In this statement that was released by the International League Against Epilepsy Psychology Task Force, urged to implement psychological treatments for adults and children with epilepsy. And the intervention ranges from cognitive behavioral therapy and mindfulness-based therapy. All were very effective in terms of improving well-being and seizure control. Now, taking you to zoom out of the picture, we want to look at neurological disorder in a general sense. It was found that in our systematic review, the mindfulness-based approaches were highly recommended as well. Now, a wee bit background about mindfulness is not where you have a skill where you levitate yourself above the ground. Our mindfulness, as defined by John Kabat-Zinn, is the ability to pay attention in the present moment on purpose with a non-judging attitude. In fact, the meta-analysis documented the benefits of mindfulness has been applied in different populations, and that includes the neurological condition such as in Parkinson's diseases, multiple sclerosis, and stroke patients. And this was a systematic review that was conducted for mindfulness applied for people with epilepsy in Wood et al. In 2017, in which they synthesized the 3 studies. But what is lacking here is that when we look at the 3 studies, there were no assessment on the levels of mindfulness and the characteristics of the epilepsy were poorly reported. Now, when we develop intervention, it's very important to look what we are assessing and looking at how effective it can be done. So the ILAE also put forward a statement that psychological intervention should consider the great recommendations, in which we look at how clinically significant is this particular intervention, where we look into the symptoms of the disorder being treated, as well as the functional outcome. And that itself makes my study different from the previous 3 synthesized study. So in our study, we look at the effectiveness of an intervention using the Reliable Change Index. The Reliable Change is actually using a standardized measure, a standardized calculation to evaluate whether a person's score changes over time. And that provides us a crude estimation, an index of detecting how many patients responded to treatment, which is very important for looking at the treatment dosages in terms of clinical practice. So flowing into the research objective, we are particularly interested in looking at the impact of the mindfulness-based intervention, the following outcome. How sustainable can it be, as well as looking at the clinical significance by assessing it using the Reliable Change Index. Now, to address the study aim, we used a randomized controlled trial design, and we recruited participants who were attending the neurology clinic. They were screened using the following selection criteria, and the epilepsy diagnosis was actually looked by our consultant, a neurologist. And then we have a neutral coordinator, which involved in allocating the participants into a pre-specified group using a computer-based randomizer, putting them into either the intervention or the waitlist control group. Now, the participants were not aware about which start date that they will enroll in. So that being said, they were randomized, and then this allows them to put them either into the intervention or the waitlist control group to attend the intervention group would attend 6 weeks of the mindfulness intervention, and then they will follow up 6 weeks after the intervention ended. So these are the outcome measures that we use to look into prior randomization at the post-intervention and at the follow-up period, where we tackle into the symptoms of depression, levels of anxiety, quality of life reported, as well as mindfulness and life satisfaction. Now, the intervention was delivered in a 2.5-hour weekly session in a group of less than 15 people, where we educate them about the link between stress and mindfulness, as well as it is a group activity in which they were able to discuss the homework practices, what barriers do they face in a very supportive environment. And meditation practices were also conducted in session, where they were taught to be aware of the breath, the body sensation, the thoughts and emotion. Of course, these sessions actually have different components, where we first teach them to be aware of the body sensation and moving on to the thoughts, accepting difficult emotions, and then spreading the positive emotions like compassion, being compassion to self and so prior analyzing or collecting the data, we did a sample size calculation to ensure that we have enough power to detect significant differences. And these are the methods used for this study. So what we can see is that who benefit from this intervention. So these 28 participants comprised of mostly female, attained tertiary education and above, and they were employed. Most of them were focal epilepsy, drug resistant, and on monotherapy. So looking into the main bulk of our study, we want to look at the impact of our intervention. A very brief 6 weeks mindfulness training allowed the participant to have improvement in terms of quality of life by being more aware, as well as reduction in symptoms of depression. In a follow-up, 6 weeks after the intervention ended, we found significant differences in the levels of mindfulness and quality of life, as well as for levels of depression. But the study did not find any significant differences for anxiety and life satisfaction. So beyond 6-week intervention group also achieved the following. Now, we want to look at how significant is that intervention in terms of looking at individual score changes across time, and we use the reliable change index to look at the outcome measures, comparing between the baseline and at the follow-up session. And we see that the patients actually in the intervention group had a reliable improvement in quality of life, levels of mindfulness, as well as better managing in levels of depression. So what we can conclude from this study is that about up to 40% of reliable improvement were found in the intervention group in terms of the reduction of psychopathology like anxiety and depression. And 46% of them actually attain levels of mindfulness. And there is a reliable improvement in terms of quality of life and life satisfaction. As a group, a brief 6 weeks intervention, and when they were follow up, the group actually managed to have lower levels of depression and better improvement in mindfulness and quality of life. Of course, this study was rather small, okay, and it may have inflated the benefits of the intervention, as we cannot extrapolate whether or not the intervention may have been different for people with learning disability or for patients with frequent seizures. However, the benefit of this study is that we use the RCI method to dictate the proportion of patients who responded to treatment. And that is very important because we can see how many of them respond. That is the treatment dosages, in which it's very important for a resource-limiting country, as well as we can look at what makes patient fail to respond or probably did not even improve. So that is actually very important, which gives rise to the new direction in this field, is that further study is required to discuss the practical concern pertaining to the treatment responses, and we need larger sample trial, objective measures to look into the changes in symptoms, and qualitative studies to look at how they actually experience the intervention itself. So although the goal of epilepsy treatment is to attain seizure freedom, which is no seizure, and the best is no side effects. So our brief 6 weeks mindfulness training, which doesn't have any side effects, right, can be incorporated into the treatment plan of people with epilepsy. In fact, this was also highly advocated in the recent education webinar to integrate psychological care services by the ILAE Psychiatric Commission. So I would like to thank you, use this time to thank my supervisors for this study, which is Professor Lim Keng Siang at the top left corner, and Professor Lo Wah Yun, as well as my clinical supervisor, Professor Dr. Venice, and the following group of friends that have helped me to cruise through this project. This is my references, and thank you.
Thank you very much, Dr. Lai, for your insightful talk. Congratulations on obtaining your PhD and also on the winning this best publication paper. So I wish you the best of luck for your future work. And now I would like to hand over the ceremony to Dr. Tan Soon Hao for the next couple of talks.